I'm very honored to be here to be your moderator for the next panel session. The first speaker is Professor Roberto Giugliani. He is a professor at the postgraduate program in genetics and molecular biology of the Federal University of Rio Grande do Sul. I tried to look up how to pronounce it, and hopefully that I do not speak like Cantonese, right? And he is also the member of the Medical Genetics Service of Hospital de Clínicas in Porto Alegre, Brazil. He is also head of rare disease at DASA Genomics and executive director of Casa do Halos, that is the home of the rare, a center of excellence in rare diseases in Brazil. He has vast international experiences. He earned his Master of Science and PhD degrees in Brazil, and he did postdoctoral trainings in London, Geneva, Paris, Zurich, Auckland, Sydney, Tokyo, and Heidelberg. So he speaks multiple languages. And he was the past president of the Brazilian Society of Medical Genetics and Genomics and the Latin American Network of Human Genetics. And he is the former director of the WHO Collaborating Center for the Development of Genetic Services in Latin America. His research interest is in the field of inborn errors of metabolism, particularly lysosomal disorders. Today, we are very happy to have Professor Roberto with us to share us with the insights into rare disease focused on the inborn errors of metabolism. Over to you.
Thank you very much for this kind introduction, and thank you for inviting me to come to Hong Kong for this International Genomic Medicine Symposium. I thank the Hong Kong Genome Institute, Rare Disease International, and the Lancet Commission on Rare Diseases. So I am Roberto Giugliani, coming from Porto Alegre in the south of Brazil. I see where is the star, and this is my city. It's about 1.5 million inhabitants, and I crossed to come to this beautiful and vibrant Hong Kong. Very pleased to be here. Thank you. These are my disclosures. And so I will show along the presentation some sense of South America, and starting with insights into rare disease very briefly. We had 4 years ago a very important resolution adopted by the General Assembly on United Nations General Assembly, addressing the challenges of persons living with a rare disease and their families. And this year, the World Health Assembly adopted another resolution on rare disease, which will drive WHO to issue policies on rare disease to be adopted by the member countries. And this had a major input of Rare Disease International and many other stakeholders. Well, rare disease is defined as rare according to its frequency. You know this, but this change from region to region. For instance, in Europe, is no more than 1 case in every 2,000. In Latin America, there are many different definitions. I took one from Colombia. They say no more than 1 case in every 5,000. And in China, as far as I know, is no more than 1 case in every 10,000. But in fact, most rare diseases, they are ultra rare, and there are no more than 1 case in every 50,000. But as you know, there are many rare diseases. This survey states that maybe more than 6,000 different rare diseases, and this other survey states more than 9,000 rare diseases. Something in this, among these numbers. So as there are many, and there are some surveys that say that between 3 and 6% of the population may have a rare disease. So this is so if you have up to 6% of the population, it means that in the world you may have up to 400 million people affected with a rare disease. And they are most genetic, but there are some non-genetic conditions. So it is estimated that around 80% have a genetic cause, and the other 20% are non-genetic. They include some rare immune conditions, some rare endocrine diseases, some rare types of cancer, and even some rare infections. Just a few weeks ago, we had that news on that, the death of the wife of the actor Gene Hackman. And she had hantavirus. Hantavirus is a rare disease, but it's an infectious disease. And rare disease affect mainly children, and this makes sense because they are mostly genetic. So 75% of the disease, of the rare disease patients, they are children or adolescents, or the disease starts in childhood or adolescence. And some are quite severe, and it is estimated that around 30% of patients will not survive the age of 5 years. And these patients, they face very frequently a diagnostic odyssey. They go from doctor to doctor, from test to test. They face hospital admissions, surgeries, and it's a long journey until the diagnosis. Fortunately, genomics is shortening this journey, and it is estimated that 40% of the patients with rare disease had at some point a wrong diagnosis. That may lead to a wrong therapy and maybe a surgery that's not necessary, and so it is important to have a precise diagnosis. And when you have a diagnosis, you can have a therapy, but therapy are available for only 5 to 10% of the rare disease. The other 90%, of course, you can do something, but not a specific therapy. Always we can do something to improve the quality of life. Well, so now let's focus on inborn errors of metabolism. The story of inborn errors of metabolism started in the beginning of 20th century when this doctor in London, Sir Archibald Garrod, he realized that some genetic disease do not lead to physical abnormalities, but may lead to biochemical abnormalities. So, and then he observed a patient with a disease that was accumulation of homogentisic acid, and he named it alkaptonuria, and published in 1902 is the first report of an inborn error of metabolism. And then he worked in other conditions like pentosuria, cystinuria, albinism that all of you know. He hypothesized that was a defect in the synthesis of melanine. So he put together all these observations, and in 1908 he published a compendium Inborn Errors of Metabolism. This was the start of this area, and basically we have a substrate that is converted into a product. This usually by an enzyme that catalyzes this reaction. This enzyme is transcribed from RNA. Sometimes this enzyme needs a cofactor. It's translated from RNA, and the RNA is transcribed from DNA. And then if you have a problem in the DNA, we will have a problem on the RNA, and then the enzyme will not work properly, and the reaction will not take place as expected, and we will accumulate the substrate, and you miss the product. So this is the overall architecture of the inborn errors of metabolism. An example, very well known, the phenylketonuria. Phenylketonuria is a disease where there is a impaired conversion of phenylalanine to tyrosine, and then there's usually because of defect in the enzyme phenylalanine hydroxylase, and sometimes because of the cofactor is not synthesized properly. Well, but at the end, we have accumulation of phenylalanine and all derivatives that are toxic, and so patients with this condition, they are born normal, but they develop a progressive mental handicap. These inborn errors of metabolism are not started with Garrod. There were many conditions described before, like this The Gaucher disease was described in the 19th century by Philippe Gaucher, but he is described as an epithelioma of the spleen, not as inborn error of metabolism. It took many years then to realize that this was a metabolic disease that leads to a massive visceromegaly because of storage of a complex molecule. Another example of a disease that was described as a independent case report, like Hurler syndrome in 1919 by Dr. Gertrude Hurler in Germany. She described this boy, and then the studies showed that there is some storage in tissues, also in blood, lymphocytes with vacuoles, some accumulation of substance in urine, and then it was identified as glycosaminoglycans that are stored in the body, and then it was discovered that some enzymes are not working properly and lead to this storage, the enzymes that should degrade these glycosaminoglycans. And this is under gene control, so this is completing the picture of an inborn error of metabolism. There are many inborn errors of metabolism. This survey in the top says around 1,000. The survey in the bottom says 1,400. So it's something in between. And so what is the proportion of inborn errors of metabolism among the genetic diseases? So we have around 24,000 genes in the human genome. At least 6,000 are related to known disease, as you just heard from Kian. This number is growing every day. So around 6,000 genes related to known disease, about 25% of the total genes. And 1,200 are conditions considered as an inborn error of metabolism, about 20% of the genetic disease. But why only these 20% are considered inborn errors of metabolism? Because they affect the biosynthesis or breakdown of substance within specific pathways. They are recognized by specific biochemical tests, and in some cases they are treatable by metabolic intervention. I will touch very briefly this. So from the 6,000 genetic diseases, about 20% are inborn errors of metabolism. And why they are important? Well, when you are working normally, like you live for a travel in a car, and you are not worried about how that car works. But if you have a problem, then of course your trip has a problem, but you can have an opportunity to discover what's the function of that part that is defective. So this is one of the important roles of the inborn errors of metabolism, to show us how the normal metabolism works. Then you maybe replace that part and have your trip again. So the metabolism is quite complicated, it's quite large. We have thousands of reactions, so there is a large number of inborn errors of metabolism. They may involve any part of the metabolism, the amino acids, carbohydrates, lipids. They are clinically heterogeneous. There is no obvious presentation in most cases, which is very challenging. And the early signs and symptoms are usually not specific. So how to investigate an inborn error of metabolism? So when should it be suspected? So while most are autosomal or X-linked recessive disease, so parental consanguinity is something that may raise a flag for the inborn errors of metabolism, or similar cases in the family, something you should be aware. Cases of early death in the family, or mental handicap with no cause identified, also important. A child has a diagnosis, but has many admissions at the hospital. We should think on inborn error of metabolism, vomiting, feeding difficulties, jaundice or cholestasis in a young child, episodes of hypoglycemia, metabolic acidosis or alkalosis, dehydration, encephalopathy without a clear explanation that may appear at any age and may be intermittent, Neurological regression, very important, and mental handicap also may be an inborn error of metabolism. Seizures also. Hepato or splenomegaly may indicate some storage, and growth failure and skeletal abnormalities may impact the bone architecture. And how to try to organize the inborn errors of metabolism, to classify? One way is to classify in 3 groups. Group one will be disease that cause intoxication. Something is accumulating this toxic, like the example I showed with phenylketonuria. The other group is not something accumulated, but something lacking, like energy. So the organism is not able to produce enough quantity of energy. What you see usually in the mitochondrial disease. There are many other, but the mitochondrial is the most important on the second group. And the third group is the disease that involves the storage of complex molecules. It's my field of interest, so I will explore a little bit more this third group. What happens is that we are continuously producing complex molecules, and you need to recycle them. We need to take them to the recycling unit, and the recycling unit of the cell is the lysosome. And there are many enzymes that degrade these complex molecules, so you do not have storage at the end. So, but when you do not have this degradation mechanism working properly, you have storage in the lysosome, storage in tissues, and clinical consequences. It's like a recycling plant, where you take your garbage there. If you are able to organize it and make it ready for recycling, okay, but if not, there will be a mess, and this is what happens in these storage diseases. And there are hundreds of lysosomes in every cell, and the enzymes are needed for the stepwise degradation of complex molecules in the lysosome. Many enzymes are there, and these are one metabolic route with one metabolic pathway with many enzymes. Any of these enzymes that is not working properly will have storage and you have problems. And in this lysosomal disease, there is a multisystemic involvement. You see in this patient hepatosplenomegaly, coarse faces, large visceromegaly on this one, joint restriction, corneal clouding, cherry red spot, all due to deposits in the tissues, skeletal abnormalities, and even brain abnormalities, as you see this leukodystrophy in this imaging. So what are the strategies to investigate an inborn error of metabolism? Of course, we depart from clinical evaluation, routine clinical pathology tests, ammonia, lactate, blood gases may help, imaging and functional tests like MRI, spirometry, biopsies, skin, liver, bone marrow, very useful. Specialized biochemical genetics tests are important, and of course, molecular biology procedures. And how to investigate? We can try to say there are 3 main approaches. One is investigation based on clinical suspicion, and you take one patient and you investigate that patient, or you can investigate groups, high-risk groups. You can do screening in high-risk groups that have some condition, that some signs or symptoms that suggest an inborn error of metabolism, or you can do mass screening, like newborn screening in all babies for specific conditions. Let's explore briefly these 3 possibilities. Start with investigation of patients based on clinical suspicion. So this patient with coarse faces, there's a clinical suspicion of a storage disease. You look for what is being stored, and if you find something, you go to which is the enzyme that is deficient that will lead to that storage. And then if you find, you go to the gene that is codifying that enzyme, and then you complete your diagnosis. But this is changing, and we are in a genomic medicine symposium. You know that from clinical suspicion many times and more you are going directly to the molecular analysis with sequencing, next-generation sequencing, panels, exome, genome, and find no mutations. Well, this does not rule out a genetic disease. We just learned from Keen about just the tip of the iceberg is the coding area. There are many other things to be identified. And, but if you find a mutation, we have to ask if the mutations lead to the enzyme deficiency. And this is so you should do the enzyme assay. And if you find the enzyme deficiency, should ask you if this enzyme deficiency is sufficient to lead to storage and look at the substrate. So the message is that if you go from one clinical, biochemical, molecular, okay, but if you go from clinical to molecular, you still need to check the biochemical results and to confirm. And the example is this boy, 8-year-old boy with epilepsy. He did a whole exome sequencing. A new variant on the IDS gene associated with MPS2 was found. The enzyme activity was 80% of normal. It was low, not that zero, but it was low, but no increase of substrate. So this, and also no clinical manifestation of the disease that is mucopolysaccharidosis type 2. So this case is not mucopolysaccharidosis type 2, but it's a pseudodeficiency. So illustrating the importance of doing the whole diagnostic approach. We can screen high-risk groups. Examples is the patients with mental disability, children admitted to intensive care units, seizures of unknown cause, proteinuria, cardiomyopathy. And I took this example from China, screening of Fabry disease in patients with left ventricular hypertrophy. And they found when around 1,000 patients, 0.88% of positives. You think low yield, less than 1%, but it's much more than you find in the population, where the incidence is about 1 to 30,000. And if you find, also important, if you find one case using pedigree, using biochemical and molecular analysis, you can find many more cases in the family, as we found in this family. So, and also that we just mass screening, newborn screening, it started with phenylketonuria. This patient, I showed this picture, this patient was born with phenylketonuria, no treatment, no screening, so she had a mental handicap. But after treatment was discovered, then you can treat the patients, but you can treat after you diagnose. And these patients are diagnosed by many months or some years to diagnose this patient, so already exposed to irreversible sequelae. So, and thinking on this, Robert Guthrie in the 60s figured out of a test to apply in all newborns. So he discovered the Guthrie test, the Guthrie card, and started screening for phenylketonuria. This child was born with phenylketonuria. If no screening, no treatment, she would be like this. But with early diagnosis and early therapy, she became a normal baby, a normal child, and a normal woman. So this is very, screening was a major advancement in medicine. So it started in the 60s with phenylketonuria. By the end of 20th century, most programs had 6 to 10 diseases, and in the early 21st century, with the adoption of tandem mass spectrometry, some progress expanded to around 60 diseases, and now with panels we can go up to 400 treatable diseases. And with genome, maybe you can screen for all these genetic diseases. Of course, makes sense only to screen for disease that you can intervene, you can treat, but it's estimated that around 1 in each 200 individuals present a treatable genetic condition. Just a few hints on therapy to finish. One of the things that the inborn errors of metabolism are important is because they are only 20% of genetic disease, but they have the major part of the treatable disease are metabolic disease. So we estimate about 500 treatable genetic disease, and most of them are inborn errors of metabolism. And why this? Because we can intervene in some of these steps, DNA, RNA, protein, substrate product, with small molecules, recombinant enzymes produced in bioreactors, gene therapy or cell therapy, so we can try to reduce the amount of substrate, you can replace the protein, we can make the protein to work better with chaperones, we can interfere on the RNA step or in the DNA with gene therapy, genome editing. We just heard also about this in the previous lectures. We can work with modifier genes, we can reduce neuroinflammation, increase neuroprotection, you can use transplantation, cell therapy with modified pluripotent stem cells. So, last slide. Rare diseases include 6,000 to 9,000 conditions with a low individual frequency and mostly originated by genetic causes. As a group, rare diseases affect up to 6% of the world's population, which would be 400 million people, and are now recognized as a global health priority. Inborn error of metabolism account for over 1,000 conditions, and its diagnosis is established after investigation of patients with suggestive clinical findings or screening of high-risk groups or by mass screening like newborn screening. Inborn errors of metabolism include most of rare diseases which have a specific therapy available, with many different therapeutic strategies in place, as substrate inhibition therapy, enzyme replacement therapy, gene therapy, genome edition, and gene cell therapy. Independent of the type of therapy, early diagnosis will continue to be a major challenge to prevent disease burden and disease progression. And newborn screening should be considered for the inborn errors of metabolism which have effective therapies available. So I thank you very much. This is a picture of my city. This is the hospital where I developed my work. This is the new Rare Disease Center, Casa dos Raros, and I am especially thankful to patients that inspire our work. Thank you very much.
Thank you, Professor Giugliani. And the floor is open for questions. Do we have any questions or comments for Professor?
Thank you. My name is Zilfalil from Malaysia. You mentioned about the WHO identifying rare disease as one of the priority, which I fully agree. However, in many low and middle income countries, rare disease is still not a priority. So many governments, they put rare disease, as something which is less important, and the focus is more on infectious diseases. So what are your thoughts on this? How do we approach this? To make rare disease a priority, especially in low and middle income countries. I'm from Malaysia. Malaysia is a middle income country. We have been campaigning to get our government over the last 10, 15 years to prioritize rare disease. And we are lucky that a few months ago, they came out with a policy on rare diseases. So I think in that sense, we are lucky, but the work has been very long. We told them that, people with rare disease, patients with rare disease should not be left behind. And I think, it's a long work, long journey, just like our patients, but I think it's worth it. What are your thoughts, I think, on, I know Brazil is also a middle-income country. How did you get your government, to prioritize rare disease? Thank you.
Thank you for your comments. Well, I come from Brazil, and we have a similar situation in terms of health priorities. But I think that what we can do is to show with data and real-world data that if you approach rare diseases, this has an impact on the budget. If you prevent the rare diseases, if you diagnose early and you reduce the cost of hospital admissions, and there are many things that we can show that if you work properly with rare disease, we will have an impact on the health, and at the end we can have is an action that has really a sense. And so I think this is, and also what we are trying to do is that rare disease may be a model to how to approach common diseases with genomics, with prevention, with screening. And so I think this is also may make the health authorities sensitive to rare diseases and identify potential benefits of working in this area. Thank you for your comments.
There's one more question there. That will be the last question for this session.
Thank you, Roberto. Elio Garcia from Mexico. In your journey in rare diseases and metabolic diseases, what is your best prediction for the next decade in terms of treatments and also equity for our patients?
Thank you, Jose Elias. Very good question about will be the. I think that what we will have in the next 10 years is to shorten the diagnostic journey with the more rational protocols using genomics, using telemedicine. I think there's also artificial intelligence, and this will decrease the time from symptoms to diagnosis. Also use of more use of screening and select the populations that may be subject to screening, and also the disease that will be subject to mass screening. And there are new therapies that are currently very expensive, like these gene therapies, and I firmly believe that we can work to reduce the cost of these therapies, and working together, as it was pointed out in the previous session, and we can do this and we can make this available for more affordable to the population, to the countries.
Thank you, Professor Giugliani, for your time. Please be seated. Thank you very much. And now I'd like to invite Dr. Libby Lee back to the stage to introduce our next speaker.
Dr. Derek Lee is a cardiologist at Queen Elizabeth Hospital, specializing in cardiomyopathy, heart failure, and inherited cardiac conditions. He is in fact a very brilliant young fellow. He received multiple accolades, including the Best Thesis Silver Award from the Hong Kong College of Physicians in 2021, the Asian Pacific Society of Cardiology Emerging Leader Scholarship in 2022, and the Joint Hong Kong College of Physicians Hong Kong Genome Institute Scholarship in 2024. He holds a master's degree in medical genetics, awarded with academic honors, and furthered his subspecialty training in inherited cardiac conditions and advanced cardiac MRI at Royal Brompton and Harrowfield Hospital in the UK. So today we are very pleased to have him to talk to us on Hong Kong, on unlocking the genomics of cardiomyopathy, a new era in heart health. So hand over to you, Derek.
Thank you, Dr. Lee. Good afternoon, distinguished guests and audience. I'm Derek Lee from Queen Elizabeth Hospital. I'll be sharing my experience with genomic medicine in cardiovascular diseases, particularly from the perspectives of cardiomyopathies. And I'm especially honored to speak after Professor Zhang's excellent lecture on her model of cardiomyopathy and rare disease care. Hopefully I can carry on the story with cardiomyopathy patients. The big fives in cardiology has always been the coronary artery disease, hypertension, followed by valvular heart disease and arrhythmias. And the last one has always been these mysterious cardiomyopathies that are often challenging to diagnose, to assess, and to manage. My interest in cardiomyopathy began during my early training years when I first met this gentleman in his mid-30s. He was a sports lover, regular swimmer. He's thriving in his career, just married, ready to build a family, but all of a sudden developed heart failure symptoms, subsequently diagnosed with MYBPC3-associated hypertrophic cardiomyopathy, complicated by outflow tract obstruction. And he had advanced phenotypes with severe ventricular impairment and diffuse fibrosis in the myocardium. But he asked me 3 questions that forever changed my life. How will my life look like? Will I die unexpectedly? And is this curable? While the diagnosis changed his life, these questions changed my career. The definitions of cardiomyopathy dates back to the 1980s, when it was first defined as heart muscle disease of uncertain cause. But fast forward a few decades later, the definition has remained essentially unchanged. Still myocardial disorder largely unexplained. There are 4 major phenotypes of cardiomyopathies, namely hypertrophic thick heart, dilated big and baggy heart, arrhythmogenic twitchy heart, and a restrictive heart that failed to relax. But underneath these phenotypes is an array of various etiologies. Here I show you 12 different patients with morphologically similar dilated cardiomyopathy, but etiologically very heterogeneous. The causes of cardiomyopathy can be divided into genetic and non-genetic causes, although the majority of these are genetic. But regardless of the causes of cardiomyopathy or the phenotypes, these patients develop one of these three major complications, namely sudden cardiac death, heart failure, atrial arrhythmia, and thromboembolic events. In 2023, a dedicated guideline on the management of cardiomyopathies was published by European Society of Cardiology, summarizing the wisdoms and pearls in the multi-parametric assessment for these cardiomyopathy patients. Although genetics was mentioned here and there in the guidelines, but when you look at the central figure here, the management of cardiomyopathies was still heavily dependent on the phenotypes, with a rather one-size-fits-all approach. But the key message here is that these are just morphologies. They are not diagnoses. And I'm going to share 3 case examples why understanding the etiologies are important. My first case was a 40-year-old gentleman with a family history of myocarditis and dilated cardiomyopathy. He presented to us with acute heart failure, and initial workup showed highly elevated troponin and severely impaired ventricular function. Because of the acute presentation, we went on to exclude significant coronary artery disease, and subsequent cardiac MRI confirmed the diagnosis of acute myocarditis. We initiated guideline-directed heart failure therapies, and with a repeat scan 3 months later, showing mild improvement but still persistently moderate LV impairment and extensive fibrosis in the myocardium. Because of the imaging features and the family history, we suspect underlying genetic basis, and subsequent panel testing confirmed the likely pathogenic truncating variant in this desmoplaskin gene. Desmoplaskin variant has been associated with arrhythmogenic cardiomyopathy, particularly the left dominant type, and it has also recently been reported to link with multiple myocarditis episodes, and which this is subsequently confirmed with multiple cohort studies with imaging evidence demonstrating inflammatory processes. Then lead to the postulation whether anti-inflammatory medications, the immunomodulatory therapies, would be useful to halt disease progression. Just 2 months ago, Cynthia James and her group in Johns Hopkins led a beautiful study, 31 institutions, more than 1,000 patients, confirming the association with the use of immunomodulatory therapies and a reduction in endpoint-free survival, heart failure events, recurrent myocarditis, and arrhythmic events. Beautifully executed etiology-based personalized management. Hopefully, this mechanistic pathway, the knowledge of this mechanistic pathway could be extrapolated to other cytoskeletal or desmosomal variants, which also demonstrate inflammatory features. On the other hand, arrhythmic risk stratification has been a big part in cardiomyopathy management, and we're increasingly moving away from the ejection fraction-based approach towards a gene-first approach. In other words, the genetic variant is the entry point for risk stratification, and numerous risk models have been developed catering different genetic variants, including desmoplaskin variants. Back to our patient, he was classified as high arrhythmic risks, and we recommended implanted in defibrillator. Just 1 month down the line, he had an episode of ventricular arrhythmia, which was successfully aborted by the ICD. 6 months later, he had a recurrent myocarditis episode, which is not an uncommon feature in these variant carriers, and we initiated anti-inflammatory therapies to prevent progression of heart failure and reduce arrhythmic risks. My second case was a 27-year-old gentleman with a long-standing childhood onset history of electrolyte loss on replacement. He has no significant family history, and he presents to us with a subacute onset of heart failure symptoms. His initial EKG showed prolonged QT interval in the context of electrolyte disturbance, and his cardiac MRI reviewed dilated cardiomyopathy with severe ventricular impairment. We initiated guideline-directed heart failure therapies, and because of his imaging features and his arrhythmic risks, we discussed and recommended defibrillator. He went on to have dilated cardiomyopathy panel, which came back negative. But because of the combination of dilated cardiomyopathy and a childhood onset salt losing feature, we suspect underlying genetic basis, which led to our pursuit with whole genome sequencing and confirmed a pathogenic missense variant in the RAGD gene, which was also mentioned by Professor Zhang early on in his talk. Because now we understand the mechanistic pathway of this RAGD gene, which has recently been reported to cause a combined dilated cardiomyopathy and renal tubulopathy via the mTOR activating pathway. This led to a heated discussion within our multidisciplinary team involving the renal physician, transplant physician, cardiomyopathy specialists, and geneticists for the possibility of targeted therapies. And by consensus, we agreed to initiate mTOR inhibition with sirolimus in this young gentleman. We talk about an arrhythmic heart, we talk about a dilated heart, and my last patient was a 43-year-old lady with an unusual hypertrophic heart. She had a past medical history of chronic kidney disease, bicuspid aortic valve, and aortopathy. She had family history of multiple sudden cardiac arrests, and she first presented to us with unexplained syncope. On initial workup, she had a rather unusual hypertrophic feature on the scan, irregular myocardial border, hypertropicalization, moderate dysfunction, significant fibrosis even in the atypical location, and clinically evidence of pre-excitation and non-sustained VT. She went on to have ablation to her accessory pathway, but in view of the imaging features and her presentation, we recommended defibrillator implantation. And on the ICD monitor, we pick up another suspected episode of accessory pathway, which then led to second ablation procedure. She had an HCM panel, which also covered some of the phenocopies, particularly the BRCA2 cardiomyopathy, Danon disease, and Fabry disease, which came back negative. She went on to have a remarkable clinical course with further deterioration within a short time and features of advanced heart failure phenotype. The overall imaging feature, hypertropicalization, multiple accessory pathway, diffuse fibrosis in a typical location are all very unusual for sarcomeric HCM, which then led to our further pursuit for other underlying rare variants. With whole genome sequencing, we confirmed a pathological missense variant in the NDUFB11 gene, which is an X-linked variant involved in energy production in mitochondria, confirming a diagnosis of mitochondrial cardiomyopathy. By consensus in the MDT, we prescribed coenzyme Q10 and riboflavin for this young lady. Hopefully, with these 3 case studies, we can illustrate 3 key messages. Number 1, the understanding of genetic basis of disease led to our understanding of mechanistic pathway and hence enabling precision medicine. Secondly, the understanding of genetic basis is crucial in the arrhythmic risk stratification in cardiomyopathies. And lastly, rare disease remains rare if we don't look for it. In the last few slides, I'm going to share a little slightly broader perspectives on the cardiovascular genomics. We used to think genetics and cardiology are straightforward. One gene is associated with one condition and vice versa. But now we understand that one gene can be associated with multiple phenotypes, and one phenotype can be caused by variants in multiple genes. Hence, the relationship is not that straightforward, and even the phenotypes themselves overlap. You will see dilated cardiomyopathy patients coming in with multiple arrhythmic episodes mimicking arrhythmogenic cardiomyopathy, and an end-stage hypertrophic cardiomyopathy coming in with a dilated heart. And further adding to the complexity is the incomplete penetrance and variable expressivity in many of these disease-associated variants. But recently, our understanding evolves as we begin to explore the polygenic model in cardiovascular diseases, where these common variants, they add up to construct unique genetic profiles of each and every one of us, and hence our individual susceptibility to various kinds of cardiovascular diseases. And perhaps even better explained with this threshold model, whereby if you or I carry an incompletely penetrant variant, the presence of second rare variants or multiple common variants would add up to reach the threshold for disease manifestation, and hence possibly altering the variant penetrance and expression. And we can call this second hit or third hit, and this is not limited to genetic modifiers, but also non-genetic modifiers such as the environmental factors. Perhaps one of the best examples is titin, which is the largest protein in the body and the most common gene associated with dilated cardiomyopathy. Titin has been implicated in several what we thought to be acquired causes of cardiomyopathy, such as alcoholic cardiomyopathy, peripartum cardiomyopathy, chemotherapy-induced cardiomyopathy, and more recently, myocarditis. The understanding that there is a genetic predisposition to various genetic disease or cardiovascular disease helps us understand, number one, why there is a huge variability in clinical presentation and severity. And secondly, it opens an avenue for intervention and even preventive strategies. For example, limitation of alcohol intake, close monitoring during the pregnancy or chemotherapy in susceptible individual, or even preventive strategies in early manifestation. Another example is high-intensity exercise in plakophilin 2 variant carrier, whereby the exercise has been shown to accelerate disease onset and progression. Hence, by carefully prescribing exercise program, we can slow down disease onset and hopefully reduce the adverse remodeling in the myocardium and arrhythmic substrates. Perhaps outside the scope of sharing today, polygenic risk models also expand our understanding in cardiomyopathies, particularly the gene-elusive cardiomyopathies, and in guiding our risk stratifications and family screening strategies. And polygenic risk models have extended its utility beyond rare diseases into common cardiovascular diseases such as coronary artery disease, hypertension, and atrial arrhythmias, which are the big fives in cardiology. In summary, ladies and gentlemen, majority of these cardiomyopathies are inherently genetic, including those we thought to be acquired causes of cardiomyopathies. Secondly, genetics in cardiomyopathies enhances our understanding of the mechanistic pathway, and hence enabling the development of precision medicine, hopefully illustrated by the 3 case studies. There is a complex interplay between the genetic and non-genetic modifiers that contribute to the development of rare as well as common cardiovascular diseases, as in the case of Titin and also PKP2 variant carrier. And finally, polygenic risk scores expand our knowledge, as illustrated just now, in rare diseases as well as common cardiovascular diseases. Thank you very much. I will end my presentation here.
Thank you so much, Dr. Derek Lee. Thank you for the insightful presentation. Please be seated. Thank you. And now I'd like to again invite Dr. Libby Lee to the stage once again to introduce our next speaker for us.
The last speaker of this session is Dr. Becky Ma. Dr. Ma is a clinical assistant professor at the University of Hong Kong, specializing in nephrology and genomic medicine. She is a graduate of Hong Kong U with distinctions, and she received her training in Queen Mary Hospital, the Hong Kong Genome Institute, and Columbian University, where she completed a postdoc fellowship in precision medicine. And Dr. Ma has garnered numerous achievements and accolades, including the Best Thesis Gold Award from the Hong Kong College of Physicians and a Distinguished Young Fellow by the Hong Kong Academy of Medicine. She received the Hong Kong College of Physicians Hong Kong Genome Institute Training Grant for Excellence in Genomic Medicine. She has been named as one of the emerging leaders by the International Society of Nephrology Emerging Leaders Program, and bestowed the Early Career Researcher Award for the Best Clinical Science Paper by the Kidney International and International Society of Nephrology. Today, Dr. Becky Ma will share with us the precision medicine in nephrology. Please, Dr. Ma.
Thank you very much, Dr. Lee, for the very kind introduction. Good morning, ladies and gentlemen. I'm Becky. I'm very honored here to deliver this talk on precision medicine and nephrology, and I really want to thank the organizing committee for giving me this opportunity. So chronic kidney disease affects 10% of the global adult population, and it is among the fastest growing causes of deaths globally. It encompasses both monogenic and polygenic etiologies, and it's estimated that around 10 to 20% of adult chronic kidney disease patients and 30 to 50% of children with chronic kidney disease actually have monogenic causes of their diseases. The relative common ones include autosomal dominant polycystic kidney disease, Alport syndrome, genetic forms of focal segmental glomerulosclerosis, and also autosomal dominant tubular interstitial kidney disease. So in view of this rising importance of genetic testing in patients with chronic kidney disease. People working in the nephrogenetics world have came together to hold this summit by the KDIGO in 2022 and also earlier this year. And this figure actually illustrated very well the multifaceted clinical utility of genetic testing in patients with chronic kidney disease. It directs precise diagnosis, which is only the very first step in properly managing our CKD patients. It informs the prognosis, guides disease-specific treatment, nephroprotective measures, and also avoid patient from unnecessary treatment or investigations due to misdiagnosis. And also it optimizes kidney transplant workup, benefiting both the recipient and donor, which I'll illustrate later on, and also inform the reproductive decisions and benefit other family members. So we have established our genetic kidney disease clinics at Queen Mary Hospital, where we help our patients to do genetic assessment, counseling, ordering genetic testing, followed by the discussion of the results, and then the post-test counseling, and then initiate disease-specific treatment, nephroprotective measures, looking for extrarenal manifestations, refer to other relevant specialties early, and also refer for reproductive counseling if needed, and also help other family members for cascade testing. And in close collaboration with the Hong Kong Genome Institute, have been actively recruiting patients to various kinds of research projects. And one of them is the whole genome sequencing in adults with chronic kidney disease of unknown etiology, CKDX. So these patients come to our nephrology clinics. So after extensive workup, the standard workup, including urinalysis, serology, imaging, and if possible, kidney biopsy, the cause of the underlying kidney disease cannot be delineated with these currently available standard of care. So the aim is to use whole genome sequencing and see the clinical diagnostic utility in these patients and also identify clinical predictors of a monogenic etiology. So we prospectively recruited 131 adult CKDX patients, and you can see that 92% of these patients are self-identified as Chinese, and 36% of these patients actually have a positive family history of kidney disease. And we identified that 1 out of 10 of these patients actually have a monogenic etiology. So these are the patients who present to us that either they've been extensively worked up or they've been expensively worked up by us, and still the etiologies are unknown. But we were able to identify that 1 out of 10 of them actually harbor monogenic causes, and Alport syndrome is the leading cause of CKDX locally, followed by renal ciliopathy. So Alport syndrome are due to genetic variants in the type 4 collagen gene, which are very important for forming our glomerular basement membrane structures. And patients who have this syndrome will present with microscopic hematuria, proteinuria, chronic kidney disease, and progress to end-stage kidney failure, while patients would need various types of renal replacement therapy, including dialysis or transplant. And studies have shown that early and timely initiation of renal protective therapy, as simple as RAAS blockade, can actually delay the timing of renal replacement therapy, delaying the patient going to hospital repeatedly to receive the dialysis or having to undergo a kidney transplant surgery, receiving lifelong immunosuppressive therapies. So previously study actually showed that ACE inhibitor used timely and early can actually delay this RRT initiation by 18 years among those with proteinuria and by 3 years among those with impaired kidney function. And importantly, nowadays the guideline I recommend actually early initiation as early as 12 to 24 months of age. And the diagnosis can only, most of the time, be achievable by molecular techniques like sequencing. So in the following time, I'd like to share with you 2 cases that will actually help the patients. The first one is a 25-year-old lady who had good past health and came to us with already end-stage kidney disease. So one important point is that chronic kidney disease is actually notorious to be a silent killer, meaning that patients can be totally asymptomatic or have very mild symptoms in the early disease stages, and they can present rather late to the medical healthcare system. So biopsy was not feasible because the kidneys are scarred, the biopsy can only yield fibrotic tissues, and also it's associated with high bleeding risk. So after all the blood tests, urinalysis, etc., the cause was unknown. And also the patient had a strong family history of chronic kidney disease of unknown etiology. And through whole genome sequencing, we identified a collagen 4 alpha 3 likely pathogenic variant that is diagnosed with Alport syndrome. And in this case, we can help the patient in multiple ways. Number one, we'll help the patient end the diagnostic odyssey. Alport syndrome is also associated with other extrarenal manifestations, so actually prompt the physician to look out for that. It informs the disease prognosis because there is a known genotype-phenotype correlation, though still there are many ongoing studies to well delineate that. It guides treatment, particularly for family members, early initiation of nephroprotective measures such as RAAS blockade, and also it informs transplant risk. As we know, that Alport syndrome does not recur after kidney transplant, which is conferring good prognosis to the patient. But there is an increased risk of anti-glomerular basement membrane disease. So it prompts the transplant physician to actually specifically look out for this complication. And also it's important in the process of selecting living-related donor because they are within the same family, so they may carry the same familial variant. And we don't want the kidney donor to undergo the same path of progressing to kidney failure as their relatives. So this is an editorial written by an Alport syndrome patient who has been misdiagnosed to have glomerulonephritis. It is actually not uncommon for these patients to be misdiagnosed as various kinds of other kidney diseases and started on treatment. So she was started on steroids during her teenage year, and she developed Cushingoid, and that had some psychological impact on her. So she described, our journeys are scattered with misdiagnosis, missed opportunities for accurate diagnosis, counterproductive medications, and overwhelming guilt when our children are diagnosed. And she pointed out the benefits of actually achieving this molecular diagnosis for her, that accurate diagnosis opens the door to important options such as understanding the treatment guidelines, identifying other family members at risk, and also starting disease-specific treatment, also the opportunities to participate in ongoing researches. So I hope through this case I've illustrated to you the multifaceted utility of genetic testing in our kidney disease patients. So the second case is a 32-year-old man. He came to us, referred to our nephrology clinic because of incidental finding of kidney cysts and also some liver cysts. So the suspicion was autosomal dominant polycystic kidney disease. But it turned out that we did the sequencing in collaboration with the Hong Kong Genome Institute and identified a pathogenic variant on the SEC63 gene, which is diagnostic of polycystic liver disease, which is very different. So in patients with autosomal dominant polycystic kidney disease, the kidneys are mainly affected. And the majority of these patients will go into kidney failure, end-stage kidney failure. While in patients with polycystic liver disease, the liver is the predominant organ that is affected, and some of them require liver transplant later on. But the kidney prognosis is good. They nearly never have this progression to end-stage kidney disease. So in this particular patient, we referred the patient timely to a liver clinic specialist for further care, and also relieved him of the worry at this relatively young age of kidney failure. So in patients with cystic kidney disease, there are actually many clinical mimickers, and it's difficult to make the diagnosis early at a young age. And in the recent KDIGO ADPKD guideline, it's very well illustrated that there are many scenarios where genetic testing is actually indicated and recommended. Also in our study, we identified that a positive family history of CKDX actually predicts positive genetic finding, though you can see that 31% of patients still don't have a positive family history, and we need to stay extra vigilant. So in conclusion, in our local CKDX cohort, we identified 1 out of every 10 of these patients actually have a monogenic etiology, and Alport syndrome is the leading cause of local CKDX, followed by renal ciliopathy. And the clinical utility of genetic testing in nephrology can extend to benefit our transplant workup. So in previous study we did in kidney transplant recipients, so these patients have undergone kidney transplant, and the major causes of mortality in these patients are cardiovascular disease, infections, and malignancy due to the lifelong immunosuppressive agents that need to be put on. And we looked for monogenic causes of these conditions. Monogenic causes of these conditions including cardiometabolic disorders, immunodeficiency, malignancy, and thrombophilia. And the diagnostic yield was up to 9.1%. And the genetic data can actually help the physicians to set specific risk targets for individual patient, arrange intensive surveillance, utilize preventive measures early, guide disease-specific therapy early, initiate timely specialty referral, and also alter the immunosuppressive agents that they have been using. And this is a graphical illustration of that. And again, the breadth of the use of genetic testing can be extended in optimizing medication use in kidney transplant recipient. So tacrolimus FK, it's a pivotal drug in kidney transplant recipients, and the current standard FK starting dose is actually derived from studies of predominantly white participants who are mostly poor metabolizers. But in our local pilot study, we did that involving 337 Chinese patients with CKD, 51% of them are actually extensive or intermediate metabolizers, meaning that the actual starting dose should be 1.5 to 2 times higher than the currently recommended dose. And also the degree of up titration or down titration should be different. So there are still many ongoing challenges in the genomic world, variants of uncertain significance, whether or not to do genetic testing in pediatric population where disease-modifying treatment is only available for adults. And also this, as mentioned by the audiences, that the diagnostic disparities globally, and also this access to therapeutics. But with this very rapid advancement in the field, I feel very positive, and also I'm very excited to be part of this task force. So in summary, monogenic kidney diseases are not rare, and genetic data can provide many clinical utility help in our patients in various ways, from diagnosis to treatment to prognosis to transplant workup to benefiting other family members and also reproductive choices. And also, the clinical utility of genetic testing is actually expanding to also being applied in the kidney transplant workup and also medication optimization. And we look forward to more internationally collaborative efforts to benefit more of our patients. So I would like to end with acknowledgement. First of all, I would like to thank the entire Hong Kong West Cluster Renal team for all the support and help in setting up the nephrogenetics service. I would like to particularly thank my mentors, Professor Daniel Chan from the Queen Mary Hospital, the University of Hong Kong, and Professor Ali Gravi from Columbia University for all the guidance and advice and teachings. And also I'd like to thank Dr. S.V. Low and also Dr. Brian Zhong and the Hong Kong Genome Institute team for all the support and help provided to us and also our patients. And also, I'd like to acknowledge the funding support from the Hong Kong Academy of Medicine, Hong Kong College of Physicians, Hong Kong Genome Institute, the Health and Medical Research Fund Research Fellowship Scheme, and also the Li Ka-shing Medical Fellowship for Internal Medicine. And also, many of our local and also overseas mentors and collaborators. And thank you very much as well for listening.
I would like to take this opportunity to thank again the organizer, the Hong Kong Genome Institute, the Rare Disease International, and the Lancet Commission on Rare Diseases to have this conference. And we have the opportunity to learn from the three experts on the stage, ranging from Inborn era of metabolism, cardiomyopathy, and also nephrogenetics. I always think that genetics and genomic medicines is very magical. Probably just next to anesthesiology. And basically, it's just playing a detective role, surveying to this world of unknown. So I would like to start the question first, in case the floor need to formulate your questions. You know, it's actually very interesting to learn from you today, and the topic is very specific. But how actually we can promote this concept to our healthcare professional and also improve the public literacy for what you have done so far. So, Roberto first.
The topic
Literacy.
of genomic medicine, well, I think with data, I was mentioning when I was questioned how to convince health authorities about the importance of this rare disease, and when you go to diseases that are not rare, I think is something that we have a lot of data. Just to mention that the cases that are not do not have a cause, how to investigate and how to approach and to identify cause and manage properly. So I think this, I think the challenge we have is to get this data, real world data, and then to show to the health systems, public, private, that it really works to work with these technologies and to have an opportunity to intervene and to prevent disease and to prevent the burden of disease in many cases, and save, at the end, save money, in addition to the benefits to the individuals.
I see. So how about Derek? How do you actually let the other cardiologists to know that they have to look deeper for genetic disease?
Thank you, Dr. Lee. I would probably take the word of Prof. Zhang earlier this morning. Service, research, and education. The case studies I just shared are individual patients. These are patients who we see day to day. But in order to expand the number of patients that can be benefited from genetic testing, and also this comprehensive program, we need to work from the system, as Prof. Zhang has shared her insights in the Peking Union Hospital. I am very passionate about expanding the patient's access to these service and testing, and hopefully I can collaborate and give a hand or join my force to enhance the patient access to these services, and while at the same time carry on the research efforts that currently is being on by the Genome Institute, as well as the Hong Kong government, particularly the Genome Project, in expanding the coverage for the patients that can be benefited from this. And moving onwards is the education of local cardiologists, and as well as being an advocacy for patients who should be more knowledgeable about what they have, and what is the options and the outlook and the model of care they should have. These are my humble insights.
I see. So I guess we do not need to worry about the Hong Kong government. Dr. Chai and also Mr. Chai and also Dr. Low has convinced the government to continue to fund the institute already. So, but I still have the question for Becky. I know that you have promoted the nephrogenetics within the hospital authority, but how do you educate your patients? How do you let the public know that we have this kind of services and they should look for, the knowledge about the nephrogenetics? What do you feel about that?
Yeah, thank you, Dr. Lee, very much for the question. I think it's a very important question to actually let the nephrologists and also the general practitioners and also the patients to actually know the importance of genetic testing and getting the molecular diagnosis early. So I think patient advocates are really important. I've encountered a few of my patients who have gone through the diagnostic odyssey journey themselves, and they are very active in terms of sharing their own experience to other fellow patients, and also building the patient group locally, and also trying to extend internationally to help more of these patients and also their extended families to get the diagnosis early. So I think their role are really important in this process. And meanwhile, I think we need to play our roles definitely, is that within the hospital authorities, that we try to do our best for the services for the patients, and also actively recruiting patients to different kinds of researches, because many of the patients, well, they think that there is no cure for the disease. So what's the point of getting the diagnosis? I think making it clear that actually getting the diagnosis is only the very first step of getting the proper management. And also, there are multiple benefits that I hope through my talk have illustrated of getting the right diagnosis of not only the management, the treatment, but also nephroprotective measures, looking for extra renal manifestations, and also early surveillance of other complications and benefiting other family members. So I think we all need to play our roles and really, really hope to help these patients and their families to kind of benefit them in terms of getting the proper care.
Okay, don't forget our real-world data as well. Just make good use of the HA real-world data. So any other questions from the floor? I know they're pushing me because the time is short, so see whether any questions from the panel. Yes, please. Upstairs, yes. Please kindly introduce yourself.
Thank you very much. Hi, I'm Fong Chat Wing from the Hong Kong Genome Hospital, from the Metabolic Medicine team. So my question is towards Professor Giugliani. So in your view, what is your vision about the treatment for metabolic diseases? For example, like drug repurposing versus gene therapy. What do you think the trend that should be? Thanks.
Well, very good question. What's the trend? I think that sometimes we can intervene with a diet, and then you can solve the problem with just a management of the food intake, and then this would be easier than doing some kind of gene therapy. But for many diseases, we need to. We will not be able to solve the problem without intervention that will at the DNA or RNA level. But I think that we should look in the disease and see what is the most effective and practical way. If you have enzyme replacement therapy, it's something that is many cases it is really very beneficial, but has the burden of having a replacement every week or every 2 weeks. So you have to weight this with a one-time therapy like gene therapy that may provide a lifetime treatment for the patient. So I think that depending on in the metabolic disease, we have the possibility of intervening in many ways, and some diseases you have available the many types of therapy, and then you have to balance the risks, the costs, and the convenience. And but I think ultimately there is a long, very important trend to develop gene therapies and also gene editing therapies to disease, to provide a one-time lifelong therapy. But this will take a while, and in between we will have to use this, what we have developed until today, the management of diet, the enzyme replacement, the molecules that promote the better function of enzymes. And so there is a whole group of therapies that we should balance and try to provide the better as possible outcome for the condition.
Okay, thank you.